This primarily treats nerve compression. Normally when you're doing an open surgery, all I can see is what my eyes are looking at directly, either through the microscope or with my own vision. The one thing that I think this gives that's very different is that the camera at the tip is angled. You basically have a slender tube, okay? And then at the tip of the tube, you have a small hole where you can pass instruments through, okay? And there's also a small camera at the tip. So it allows us, when we're doing surgery, not have to make a larger incision to see everything. You basically put the scope in the spine and let the scope do all the visualization for you. Smaller incisions, less collateral damage. The first thing some of these patients would be like, what kind of magic did you do? Because I wasn't expecting the recovery process to be like that. So for me, that's very satisfying.
Welcome to our Doctors Networking group. I really appreciate you here. Today I'm here with Dr. Usman Zahir, an endoscopic surgeon who specializes in an approach that is not very common right now, but is actually much better in most cases than traditional approach. I saw a video how he actually is able to very precisely treat herniated disc, something that is very debilitating for a lot of people. And most people are afraid of complications after a procedure, but with his approach, the complications are much less likely because it's much less invasive. So I'm very, very impressed and super happy to welcome him here. I'm even more impressed researching and reading about him because I find out that he's not only a very good surgeon, an excellent surgeon, I should say, he's also teaching other surgeons how to switch from traditional approach to this amazing approach. So Dr. Zahir, welcome to our Doctors Networking group. I really appreciate you here.
Thank you very much for the opportunity, and thank you for reaching out. I think this is a great platform, and I'm really excited to talk more about this. Absolutely.
Thank you. So tell us a little bit more about yourself. Where do you practice, and also how long you've been in practice so people have a good idea?
Yeah, absolutely. So I finished my fellowship in 2012. So I've been in practice for about 8 years. And I've been kind of in the DC metropolitan region. For the first 5 years, I was doing a little bit of work in DC, but I was primarily in Southern Maryland. And then for a while, I was in Virginia. Right now, my practice is based out of Potomac, Maryland. It's in North Bethesda. I do surgeries in Maryland and Virginia. So I do have patients who travel from Virginia. A lot of those patients I will do in Virginia, and patients from Maryland, I'll do in Maryland. And kind of patients from the DC area, I'll do it in Maryland as well, because it's kind of closer to where the hospitals I work at. But yeah, so that's basically the situation. I'm in a practice with 2 other orthopedic surgeons. I do just spine, and I have 2 other colleagues. And, we have some, other services on site as well. And at this specific location where I'm at, I've been there for about almost 2 years. Just almost 2 years. Yeah.
Got it. Awesome. And I'm very close to you because I'm in Clarksburg. So definitely for that kind of procedure, people will travel a longer distance. So tell us a little bit more specifically about that procedure. So what is endoscopic approach? And also, is it new or is it something that's been here for a while?
That's a great question. So, I'll give you a little bit of background about my training. I was trained, with kind of a traditional spine program where there was a lot of trauma. We're taking care of a lot of big surgeries, kind of complex surgeries. And so that's an extremely important skill set to have because there are patients who present with those types of issues. But then you also have patients who have they may have a back problem, but they only have one specific nerve root that's affected, okay? And they might have some other things, arthritis, maybe a little bit of instability at another level. And in many cases, that's kind of like background noise. It's just it's like a forest. And you can get kind of lost in all this. But I think as you talk to the patients, you'll find out that a lot of their symptoms are coming from just one nerve, okay? And what endoscopics allows us to do is to kind of focus on the primary source of where the patient's pain is. So that's basically the approach. And basically, instead of making, larger incisions and you're doing a lot of collateral damage, you're going through muscles, you're cutting through ligaments, you're removing, joints. We have the facet joints in the back. Oftentimes you have to remove that. With this, you're just using a small device like this. So this is a an older generation of the endoscope, but the concept is the same. You know, you basically have a slender tube, and you know, this is not new technology. You know, general surgeons use this in laparoscopic surgery. Arthroscopic surgery in the knee and shoulder, people use very similar devices. Urologists use it for bladder issues. So these are very common instruments. So the technology is not new. You basically have a slender tube, okay? And then at the tip of the tube, you have a small hole where you can pass instruments through, okay? And there's also a small camera at the tip. So it allows us, you know, when we're doing surgery, not have to make a larger incision to see everything. You basically put the scope in the spine and let the scope do all the visualization for you. So that allows us to do, you know, very smaller incisions, less collateral damage. And, you know, I think that's one of the big advantages. And, you know, this technology is not new. I mean, this has been, you know, available in other specialties. And specifically for the spine in Asia and Europe, it's actually very common. And you know, I think in Asia, it's almost like the standard of care for treating disc herniations and certain types of stenosis. And in Europe as well, it's very, very popular and common. So, you know, part of it has been, you know, a lot of these places, they started adopting it early. So the learning curve they've kind of gone through that learning curve process. You know, for instance, in the United States, this was just approved by Medicare in 2017. So wow. This technology has been here for, you know, people have been doing this since the early 2000s in some countries. But here in the US, you know, unfortunately for us to do procedures, people want to be reimbursed for it. And, you know, Medicare had never approved it as a, you know, an acceptable procedure. So now it's been approved. And now for that reason, now there's a increased interest in learning the technique. Because otherwise, people would have to pay out of pocket for these types of procedures. And, you know, that's basically always a barrier to usage.
Yeah, so that's, I'm very impressed overall with the level of precision, because I saw the video, how you are able to target a specific area and gently go around the nerve to make sure right. that we are not injuring the patient, and at the same time removing everything that you need to remove. Very, very, very impressive. And of course, it's sad that, you know, we had to wait. I say we here in this country, we had to wait such a long time for this to be approved by Medicare. But on the flip side, it's actually very good that it is approved right now. So even if it's the last, about 3 years, we are able to do that through insurance, and it's an approved procedure. So that's very good. I always look at the positive. So going forward, it is approved, and that's great. I think that one of the biggest concerns that people have with surgery, and maybe that's why people are afraid of surgeries. That's why surgery has a bad reputation a little bit, because of those consequences, because of the repeat procedures that they have to go through and the recovery time. If right. you don't mind, this is the part that I'm very interested in. The difference between traditional approach, and I'm talking about a patient that you could do either or. If you could do one, let's say spinal fusion, or you could do the endoscopic procedure, what's the difference in the recovery time? What's the difference in the outcome? And also the secondary surgery that is needed after that in terms of stuff?
No, I think that's a very good question. So I think it ultimately comes down to the fact that there are a few things I think as doctors we have to think about. Number one, every time we make an incision on a patient, we're doing a form of trauma. Okay, we're doing a form of harm. Okay, so you know, as part of the Hippocratic Oath, part of our whole philosophy is first do no harm. So then the question is, that the decision has been made to do a surgical procedure. I think from an ethical perspective, it's like, what is the most minimalist approach that can be used that can still accomplish the same goals with similar outcomes? Obviously, if you're going to do a procedure, even if its incision is like this, but it doesn't solve the problem, haven't really done the patient a service. So number one, you have to be able to accomplish the goals. So all else being equal, if you can accomplish the goal through an incision this big compared to an incision this big, I mean, it's kind of our responsibility to develop a skill set so we can do it that way. So that's number one. The second thing I would say is, you know, I think as physicians and surgeons, you know, we're all trained not to just focus on the MRI and just what the images show. You know, if I got an MRI of everybody in the United States, a good majority are going to have abnormal findings on their MRIs and X-rays. Everybody's going to have abnormal findings. The key part is, what is the specific problem that they're coming to see you for? You know, so, and that comes down to, you know, very detailed history taking and exam skills, focusing on exactly what they're coming from. And then once that's done, and once you've got your diagnosis correct, right, then you can kind of pick, you know, if you need spinal fusion or if you need endoscopic type procedure, then you can go to that step. So I think that's usually the first problem that I see is people, you know, look at the X-rays, they look at the MRI, oh, this person has a spondylolisthesis, they have stenosis, oh, they need a fusion. You talk to the patient a little bit more, they have no back pain, they have no back pain, and they're saying, Dr. Zahir, all I have is a little bit of pain in my right leg. So, you know, if we get X-rays and we're able to kind of make a plan, whereas through a traditional approach, many people will be saying, oh yeah, that person needs a fusion. With some of these newer techniques, you could be like, you know, I think since this patient, even though they have the findings that I normally would in the textbook do a fusion for, okay, because their symptoms are so focal and I can isolate it to a specific nerve root, guess what? I'm just going to put a little scope in there and I'm just going to open up that nerve. So, and now from a recovery process, I mean, there's no comparison. I mean, you know, when you're just doing a foraminotomy, just going in there and just opening up the channel for the nerve, you're not fusing the patient, you're not putting any rods and screws in the back. So a lot of the restrictions after surgery are because of the hardware that we're putting in. You know, we don't want them to bend and twist. We don't want them to do this. We want them to wait, you know, 6 months or a year for the fusion to occur. But in this type of procedure, if you're just going in and opening up and providing more space for the nerve, I haven't done anything altering the normal range of motion of the spine. There's no real restrictions on the patient at all, except, you know, we just tell the patient you might have some incisional soreness. And, you know, depending on the findings, of course, if someone had a very large disc herniation that I had to remove through this, I might tell them for the first, you know, period of time, maybe avoid heavy lifting for an X period of time. But I'm not going to restrict them the same way that you would with the fusion surgery. So, you know, I think those are the kind of aspects of it. Number one, key part is the diagnosis, number one, and then linking that specifically to the symptoms that they're coming for, and then picking the least invasive option for that. And then, of course, when you pick endoscopics versus fusion, I mean, there's no comparison as far as the, you know, recovery process.
Wow, this is so valuable. And it's not only looking at you as a provider and how you analyze the situation, but also thinking from the patient's perspective.
Yeah.
They trust the surgeon, they trust the team of doctors to do the best, and like you said, do no harm and do the best procedure. But it's just some people don't have this type of procedure in their toolbox, and it's very good that you're able to analyze and pinpoint exactly for that situation, what do I do. We talked on the phone briefly about spondylolisthesis specifically, and we know that, like, I mean, this is something that is a condition, but it depends which grade. Is it stable? Is it not? What exactly the symptoms are? So looking at all those variables is definitely playing a big role, and having somebody with experience evaluating. Right now, I want to talk to our providers, our doctors in the group. Keep in mind that sometimes you want, if you're a chiropractor, if you're a rehab specialist, you may want to at least consult with Dr. Zahir and figure out what is the best approach, because obviously on the rehab side, everybody's trying to avoid surgeons as much as they can, because we treat that as a last resort. For me personally, what matters the most is being informed, looking at options and having the team approach. So in this case, what you're talking about, I think you would be open to having some conversations about a patient, even if surgery may be in the plan down the road as a possible option, evaluating and helping them even with the rehab.
Yeah, absolutely. You know, a lot of my practice is actually of second opinions. And actually, you know, we've had patients come from around the country for, you know, second opinions. Now, of course, with televisits, you can do these televisits, you know, on the computer. And it's a very similar situation. You know, there may be someone who is just unsure what their diagnosis is. Okay, number one, they just don't think their diagnosis is correct. Or a second situation where someone has been referred for a spine, you know, they're planning on getting a spine fusion surgery, and they just want another surgeon to just take a look at it and see if maybe another option is available for them, and they can maybe avoid that potentially. And some people are like, you know, I'm already scheduled for surgery already. Can you just eyeball my pictures and see if this is a good plan, I'm happy to do that as well. Even if they don't have surgery by me, I really enjoy that sort of teaching aspect about it, because I think if, if we can kind of help a patient have a better understanding of what their condition is, even if, let's say, I'm not doing the surgical procedure, we're still providing a service. As surgeons or physicians, just because someone's coming in the office and we're not doing surgery on them, we still provide advice. We can still provide advice. We can still provide, education, as far as what the options are. And I think that sometimes can put their mind to peace. I have this X-ray that shows this, and someone recommended me for physical therapy. I'm a little nervous. Am I going to damage my spine? And I look at him like, you should definitely do therapy. It's going to be totally fine. It's not a problem. So sometimes it's just that sort of reassurance that, everything is okay. And then that's half of for the patients, just have this fear that they're going to hurt themselves or something,
Of course. Yeah, this is an approach that is very, very valuable, especially that in these days, I mean, this from a provider perspective, it's very, very rare that somebody comes to you with one diagnosis.
Yeah.
They usually will have a disc issue, but there is also some bone sparing, and there is this, and there is that. And they, on the patient side, they're very, very confused, and they go from provider to provider, and on the surface, they feel pain. So they don't know, should I go through pain and continue with my rehab? Like my personal trainer may say, you may be able to do it. Then maybe the chiropractic doctor is able to do certain things naturally, or a physical therapist.
Right.
But having you in the mix to be able to evaluate and be there if needed, I think is very, very valuable for all sides. So that's amazing. Let's talk about specific conditions, specific diagnoses that you are looking for. That, for example, if a provider or a patient, if they hear from their doctor, you have this, right? So let's say it's herniated disc, spondylolisthesis, spinal stenosis, bone spurs, even, because I heard that you can even treat bone spurs with this, which is unbelievable.
Yeah, a lot of videos. Yeah.
Give us a few trigger words that would suggest that they should consult you.
Very good question. So I would say all those diagnoses above are perfectly acceptable, but I would just tell them to focus on the symptoms that they have. So for instance, I'll give you an example. If I have a patient that's coming to me and they may have any of those diagnoses you mentioned above, herniated disc, spondylolisthesis, stenosis, et cetera, but their only complaint is back pain. That's all they have. This is not going to work. It's not going to work for them if it's purely back pain. So the key part is any of those diagnoses, but they have pain in the leg. And the pain in the leg is their dominant symptom, okay? At least 50% of their symptoms. So I would say if someone has any of those diagnoses you mentioned, any one of them, and they have primarily pain in one leg, I can also address pain in both legs, but the home run cases, I'm talking about where the outcomes are the best with this, it's usually pain in just one leg. And it's maybe the majority of what they're describing. It's kind of going down from the buttock down in the leg into the foot, or it could be just in the proximal thigh, or hip area. Any of those symptoms, we can oftentimes treat it with this. The classic diagnoses that I would say are textbook for this would be disc herniations, because disc herniations typically cause leg pain. If someone just has a disc herniation, they're just having a little bit of back stiffness and back pain, I think they definitely should, of course, exhaust physical therapy, chiropractic treatments, et cetera, whatever it might be. But I think in those cases, I would have to really critically look and examine those patients, because sometimes they may say back pain, but they're actually pointing to one side of their body. And it's more like a kind of a radicular type thing. They may say, oh yeah, my back hurts. It's really my back. But when they touch themselves, they're actually pointing to their flank and their right butt area. So it's primarily a radicular. And that's someone who would do very well with endoscopics. But the kind of people who just have mid-back pain, just in the middle of their back, of course I would have to take a look at the pictures, but I think those patients, and if there's a lot of arthritis and they're just having those types of symptoms, I think the endoscopic approach may not be the best solution for them.
Got it.
This primarily treats nerve compression. So any symptoms related to a compressed nerve, it'll treat it. Pretty much almost in any case.
Very good to know. So you're looking not only at the diagnosis itself, you're definitely looking at the symptoms. The home run, like you mentioned, is going to be somebody who has either pain down the leg or any of the sciatica related symptoms. Drop foot as well, or no?
Oh, yes, absolutely. Yeah, foot drop, any kind of weakness, you know, because oftentimes that'll be associated with a herniated disc, a foraminal disc, or a paracentral disc. Absolutely. This is what this, you know, procedure is primarily geared towards. The other kind of indications like stenosis we can treat as well. You know, like a partial hemilaminectomy. A partial laminectomy I can also do through the scope. So, you know, you don't have to make a large incision. I can just do it through the scope. So all those conditions as well. As we start getting more into just pain in the back and, you know, kind of stiffness type complaints, it's not going to work as well. And I do have a fair number of patients who come to see me because they know I do endoscopics and I have a bit of a reputation for it, you know, and they think that this is a tool that can fix all problems. And then I just have to give them a little bit of a reality check that, look, you know, this is, at the end of the day, this is just a tool, but it can only treat a specific type of complaint a patient has and a specific diagnosis. So it's not like it's like a magic wand that can just fix everything with the spine. It's not like, you know, I have some patients who come in with severe deformity. I mean, their spine is completely deformed, and you know, they're having back pain related to that. And I just have to tell them, I'm like, you know, unfortunately, I can't help them with this. You know, that's something where, you know, they may need, you know, a more, you know, larger type, you know, type of procedure. But even in those cases, you know, there are some other conservative treatment options that a pain management professional could provide, you know, a spinal cord stimulator or maybe a pain pump. There are lots of other devices that might be able to avoid that patient having a huge operation, especially in the elderly. You know, you see a lot of these elderly patients who are, you know, late 60s and late 70s, and they have some sort of deformity. They may have you know, a fair amount of back pain. I mean, I think people should really be cautious about doing any kind of large fusion operation on those patients and really exhaust not just non-operative treatment, but if they need something, you know, look at some, you know, interventional pain procedures that might be able to, you know, buy some time.
It's very good to know that you are able to collaborate with providers. And when we talked on the phone, we were talking about different types of connections that may be beneficial to you and also how you can be beneficial for them. We have very good pain management specialists, some of which we mutually know. Some other ones also, they do SCS procedures. So if you need any referrals, just let me know, because we have quite a good network right now, especially in our area. I wanted to also ask you how we talked about it, and I know, but I wanted you to tell our viewers how your practice has changed since you started endoscopic surgery.
Oh, it's been a huge change. I mean, I'll say this, the number of fusions that I do have dropped significantly. I mean, I really don't need to do as many fusions. And, you know, it's an interesting paradigm. And I think the more I think about this, I'm thinking about all those patients that I treated in my past. I'm talking about 8-10 years ago. And I'm like, you know, that patient could have probably got an endoscopic approach, maybe avoided a fusion. So I think now the biggest change that I have seen is the number of patients that I'm able to treat their symptoms without having to fuse them. That's been the number one thing. The second thing is the secondary effect of that is overall having, for the most part, happy patients. Of course, there's always going to be a patient who had the endoscopic approach and it didn't provide the relief that they were hoping for. But if you look as a whole, you know, when we have those fusion patients who are getting fusions in these bigger cases, you know, they're still having issues. They may have a back issue. They may have their recovery process is slow. You know, it generates a lot of phone calls to the practice, and there are all these kind of management things that you have to do with them. And eventually, a lot of them still do well. It's just a very slow rehab type process. You know, with this procedure, it's like the kind of other type of questions or the kind of concerns patients have, you know, the recovery is just very quick. You know, initially when I would do these procedures, you know, I would write them a prescription for the number of pain medicines that I normally would write for my other procedures. And I can say a good number of those patients would come back and they were like, I never filled the prescription. I didn't really need it. So, you know, obviously also from, you know, the whole opioid crisis type situation that we're in, and the concern among the general public that, you know, procedures like spine surgeries and other bigger surgeries get some, you know, patients may end up taking pain medicines afterwards. Maybe they were on pain medicines before. That definitely is the case. But many cases, patients may become dependent on the medicines after the surgery. You know, they may have a little bit of it. So the thing is, everything that we do has a secondary effect. There's always a consequence to everything that we do as professionals. So if we can find kind of options that are less invasive initially, and we can weed out some patients that, you know, I think overall, we might not need to do a lot of these larger procedures on a lot of patients. I think that's been the biggest change. My fusion rates, the number of fusions that I'm doing have dropped significantly.
How many % would you say on average?
I mean, I think it's pretty extensive. I mean, I think I'm probably doing maybe 20, 25% as many fusions as I was doing maybe just a few years ago. Part of it's also because patients are coming to see me with those types of conditions that typically you can treat endoscopic. So the proportion of that has grown.
Understood.
So that's also part of it we have to keep in mind. So, you know, the absolute, I mean, I still do, you know, a decent number of fusions, but when you look at it from that perspective, it kind of makes sense. There's been a higher percentage of people coming in with these sort of disc herniations and very focal type symptoms because, you know, they're looking for less invasive options. And the other thing to keep in mind is that even if you can't do an endoscopic approach, you know, the kind of gold standard for this procedure, for the disc herniation, for instance, is something called a microdiscectomy.
Yes.
Which is still a very good procedure. It's very minimally invasive, I think, but microdiscectomy is different to different physicians. Some people will make a larger open incision, they'll put a retractor in, peeling with the muscles. Some of them will use a tube, you know, and there are pros and cons to all of that. The one thing that I think this gives that's very different is that the camera at the tip is angled. It's angled. So normally when you're doing an open surgery, all I can see is what my eyes are looking at directly, either through the microscope or with my own vision. If I want to look underneath the nerve, I have to take the microscope and I have to tilt it. I have to do all this. With this, none of that. You just put the camera in, it's already angled. So you can move the amount of visualization. And I mean, I'll probably be having some more videos that I'm going to be posting. It's pretty impressive because you can just rotate. I'm just rotating my fingers and I'm seeing a 40-degree view the other way. Rotate a little bit this way, you're seeing 40 degrees the other way. So you're allowed to do, your visualization is actually better, in my opinion, with this type of approach. So
wow.
The traditional surgeries are still very good for disc herniations. Like I think microdiscectomy, if you look at patients, I think at the 6-week or 3-month mark, I think if you looked at someone who had an endoscopic approach and a microdiscectomy approach, which is still very minimally invasive, patients are doing about the same. I think the only big difference that I see in my patients is that first 6-week period, you know, they're going back to work quicker. That's a big thing. They're going back to work quicker, less need for pain medications. And, you know, I generally have less restrictions on these patients. I really don't have much restrictions on them at all.
I love that. That's why they probably recover much quicker,
yeah,
especially much quicker than the traditional larger surgeries like fusion. I was very impressed at that part of your video that you said that we should always be patient. Oh, by we, you mean physicians. We should always be patient
as you would
to remove all the fragments and to carefully examine and be patient with that, because there is always, you know, sometimes you don't see it, but there's always something that can be hiding there, and then you're removing it. And then while I'm watching the video, I can see you actually do it. And it seems like you're done, and then you're removing a larger fragment.
Oh, yeah.
That is just unbelievable, because without the endoscopic approach, without being able to tilt the camera, and without your experience and patience, I think it would be so easy to say we're done because it looks clean, but it's not.
Actually, so there are benefits to both approaches. So with the open approach, because, you know, you're making a slightly larger incision, you know, you can put larger tools in. You can press in the disc and look for, you know, recurrent. But there's always a balance. As surgeons, we have to figure out when is it enough, you know, because someone can keep going and grabbing on things, and you don't want to do that. You just want to remove the kind of fragments that appear loose, and loose in the sense that you think that if I just left it this way, if they went and bent their back or did something else, this fragment is going to spit out within a week or two. And then, you know, that's why, you know, these discectomies are such basic and simple procedures, but they can be very challenging in the sense that you think you've done a very good job and you're about to, and then you just go look and you say, oh my God, there's another big fragment here. It like plays games with you in many cases. So you just have to be patient and not rush through these things, because part of the learning curve with endoscopic spine surgery is that a lot of surgeons who first adopt this technique, they'll go in, they'll take one big fragment, they're like, oh, it's done. You know, it's like time to celebrate, they'll close the wound, everything is done. And what they found, you know, you'll see these patients, they'll still have leg issues afterwards. And the reason is there were still some fragments that were missing. And, everything is magnified on this. So when you see a big fragment, you think it's very big, you take it out, you're like, oh yeah, it's decent size, I think it's done. But in reality, there's more there. And I think part of, with this, you can rotate the camera, you can look under the nerve, and you can search out fragments that may have migrated. I'll tell you an example. There are many cases where you will get an MRI on a patient, okay? And it shows a disc herniation, okay? But we were like, all right, let's try some physical therapy, let's try injections and everything. And they've been doing this for, let's say, 4 or 5 months, okay? And they come back, they're like, Dr. Zahir, none of this is working. I feel like my leg pain's getting worse. I want to have surgery. I think some surgeons may consider repeating the MRI, because you'll be surprised, a lot may have changed during that time. But not all of us get new MRIs. I normally don't, unless there's something dramatically different. But I will tell you, I can't tell you how many surgeries I've done where I go in based on what I see on the MRI, and when I'm there, I see more stuff, because there's likely been some progression since then. So I think when you're doing these surgeries, you have to keep in mind that, okay, this person's symptoms have progressed since he had this MRI 6 months ago. So I need to be prepared to look for other hidden discs that may have migrated in other areas. And that's where I think this becomes helpful, because you can really track down, look underneath the nerve, you can look in other areas and see if there's been a fragment that has moved, in a different location. So those are advantages.
Yes, very, very fascinating. I have another question that I'm really curious about. So let's say there is a fragmentation. So disc herniation, we have fragments, they're floating around in our body. What happens to those fragments over time? Do they calcify? Do they get calcified? Do they get absorbed? What happens?
Very good question. Both. They can do both. So it's a good question. So a lot of disc herniations, which we talk about as extrusions, let's say, for instance, you got a disc herniation and it just popped out and it's detached from the disc completely. It's like a free floating fragment. A lot of those will just get resorbed. The body will kind of resorb it. In some cases, they can calcify. And, I think, I've seen, I can't tell you how many times I've been fooled in a way where I can't, early on in my training, or when I first started, I had this one patient who came in, and a young guy, he had a huge disc herniation. I mean, it was massive. But, he was trying out for, the police force, and he was like, look, I can't get surgery. I got to find a way to get through this. So he had an epidural injection. He pushed through. He had the thing. And I never saw him again. But in my mind, I thought that guy was going to need surgery, because it was a massive disc herniation. And, he's like, it pain completely went away. So the size of the disc herniation doesn't matter as much. It's based on the symptoms that they're having. And if the symptoms resolve, I think in many cases you can kind of just let go, because many of those fragments will just, get resorbed with time. However, if you have someone who has a disc herniation, and let's say there's a loose fragment, and they're having persistent symptoms that are going on for years, like another year, 2 years, I can guarantee you that disc is likely calcified by then. And so now when we have to do surgery, we have to do a little bit more work to remove that. Because normally, if you saw that surgery that it's like crab meat. That disc material is very brittle. It just comes right out. But when it becomes calcified and scarred down, then we have to do a little bit more work to peel things off. And so what happens in those cases, there's more bleeding, there's more scar tissue. Patients typically have less than ideal outcomes. And there's lots of research studies that have looked at this for patients who have, and I'm talking about symptomatic disc herniation. They did, the sports trial where they looked at, if you're having symptoms and, you failed conservative treatment and you're within that 3 to 4 month type window and you get treated, I think your outcomes generally are better compared to someone who's waited for 6 months or a year with the same type of symptoms, because I think that ongoing compression on the nerve likely has some deleterious effects on the function of that nerve. So even once the surgery is done, pressure is off, those patients still have some residual issues, either leg pain or maybe some weakness because of that ongoing kind of compression. So I think I kind of went off topic a little bit. Your main question was about the discs, whether or not they get resorbed or they get calcified. And I would say it's a mix of both.
Fragments, because when we did in our rehab facility, one of the contraindications, for example, for spinal decompression that is non-surgical was having disc fragmentations. And then sometimes I saw something that looked like a fragment on the x-ray, for example, or an MRI. And I was curious because some of them, if you're visualizing them on an x-ray, that means that they must have calcified a little bit because you cannot really see soft tissue on an x-ray that well. So it was just my personal question. I'm curious because I'm not a provider myself. I'm curious what happens to those, so they can either get resorb and disappear, or maybe they could calcify.
Yeah.
And it's so fascinating, like you mentioned, there is a lot of variables because we are talking about the symptoms on top of the diagnosis itself. Now, symptoms are correlated with your pain threshold and also with your psychology, because some people are going to just, try to go as long as they can and walk through the pain and exercise through the pain. So I think the team approach in this context is very good because people deal with this. Even Bruce Lee, he was dealing with major pain related to his kids. Unbelievable. Maybe if he met you, he would be even better. So how can we as a doctors networking group, how can we as a community, how can we support you?
Yeah, I mean, I think, I think it's just awareness is probably the main thing. There are a lot of nice, good spine surgeons in the area, generally speaking. And, I think certain surgeons are good at doing certain things than others. Like, I don't do a lot of deformity work. I don't do big, large scoliosis surgeries. That's not what my interest is. So I'm kind of super specialized within the spine on doing these kind of minimally invasive. So I think if someone has, let's say a large scoliosis and the patient's like, or the provider's like, I think this patient may need surgery, it may be worthwhile seeking out a deformity surgeon, someone who does that type of surgery all the time. Whereas if there's someone more with a, more just isolated leg pain, and that patient is like, I was told I need a fusion surgery. I'm a little nervous about it. I don't know if I really want to do that. Can I get a second opinion? I'm happy to provide a second opinion on those cases, because those are the patients that I really enjoy taking care of, because, they, in their mind, those poor patients are thinking they're going to need a fusion. And, I'll just do a small 1 centimeter incision and I take care of the problem. And the first thing some of these patients would be like, what kind of magic did you do? Because I wasn't expecting the recovery process to be like that. So for me, that's very satisfying. And so I think for me, I'm always not necessarily pushing the envelope on what type of crazy type case I can take and treat it minimally invasively like this. But I think it's kind of nice where each of these patients and their feedback kind of reinforces that practice pattern for me, that I'm definitely doing the right thing. And the things that I'm doing are correlated with what people in Europe and in Asia are doing as well. They've seen the same type of benefit. And I would have to say, I'm very, humble in my kind of skill sets. If you look at what they're doing in Asia, it'll blow your mind away. I mean, they're really pushing the envelope in cases where I never even thought was possible to do endoscopics. So I think this is a paradigm shift in spine surgery. And, this technology has been available in shoulder surgery, hip and knee surgery for years. And it's just taken some time to come in spine. And I think it's going to change a lot of practice patterns for a lot of surgeons, over the long term. Yeah.
Very, very optimistic, very exciting. And this is a good thing. It's just like the 4-minute mile. So if you see other people performing those procedures successfully for conditions that maybe we would think that it's not possible, but you see that it is, it allows more progress in the United States as well. And that's very good. That's what we want. Tell our providers how they can and how they should contact you if they have a question.
Yeah, so, obviously, directly, anyone is, welcome to contact me directly. I do have a website, www.scopespine.com. Through there, there's a little prompt there. People can send messages through their patients, etc. If a provider wants to contact me directly, I'm happy to give my cell phone number. I can give it to you after the call or whatever, and then you can use that. I'm happy to have people call me directly. I'm totally okay with that. Totally fine with that. Yeah.
Super.
So usually if it's from another provider, I would actually prefer having a one-on-one conversation rather than just calling the office and getting stuck on the phone tree. You can just call me directly. Yeah.
Super. Thank you. And I wanted to ask you, just to make sure we know what is the best way to contact you. And you are very responsive. For a very busy person, you are very responsive, which is also super important because a lot of people are in pain, and that creates additional urgency to help the patient. Thank you so much. And thank you so much for watching. We invite you here to join our Doctors Networking Group, Polish Your Life. If you are a provider, if you support our providers, you're more than welcome to join our group. And if you're watching this on YouTube, subscribe to our channel. If you're watching this on Facebook or other platforms, follow us, because we will be bringing more knowledge and amazing people just like Dr. Z. Dr. Z, once again, thank you. Have a wonderful day.
No problem. Thank you very much for having me.